So our next topic is Apabahuka. It's a disease that affects the Amsa-sandy or the shoulder joint by vitiated vata. So it's considered as a vata vyadhi, but it's not mentioned among the Nanatmaja vata vyadhis. But still, Susruta and Vapada has considered it under the context of vata vyadhi. So in Matha Nidana has mentioned different terminologies, that is Amsa-shosha and Apabahuka. So Amsa-shosha can be considered, Shosha is wasting of the shoulder. It can be considered as the preliminary stage of this disease, where there is a loss of dryness of the Shleshaka kapha from the Amsa-sandy. The lubrication is lost, and following that there is a wasting of the shoulder joint. And in the next stage there is a loss of Shleshaka kapha, and symptoms like Shula and Stambhala or restricted movement, etc. are manifested. So Amsa-shosha is the preliminary stage, and followed by Apabahuka. Apabahuka, it is derived from the terms Apa or Ava and Bahuka. So Apa or Avabahuka. Apabahuka and Avabahuka are similar terms. So Apa or Ava, it indicates Viyoga or Vikrita to the Sandhi, that is dysfunction, separation or deterioration of that part. And Bahuka in general leads to the arm, it indicates arm, and there is some kind of deterioration in the functions of arm. That is the derivation or literal meaning of Apabahuka. And when we consider Amsa-sandy or the area of deterioration or the involvement of this disease, the basic information is that it's a Chala-sandy, it's an Ulukala-sandy, it's a ball and socket type. Then Shleshaka kapha is needed for the lubrication for movement of the joint. And in the marma context, you can see Amsa is a marma. So it's Amsa marma, it is a Snayu marma, and it's a Vaikalyakara marma. And any injury to a Vaikalyakara marma, the trauma, it can produce disability or deformity of the area, that is of the shoulder joint. And in modern science, it can be compared to various musculoskeletal disorders of the shoulder joint and the brachial plexus neuropathy. And when we consider the nidanas, we can see it's vata vyadhi, so almost all the causes which vitiates vata told in the nidana, vata vyadhi, samanya nidana can be included in this. And it can be divided into Bahya Hetu and Abhyantara Hetu. So Bahya Hetu means it causes injury to the marma or trauma to the region surrounding the Amsa-sandy, external force in Bahya Pikataja, and it leads to the manifestation of the Vyadhi or the disease first. And then the Abhyantara Hetu, it includes indulging of various etiological factors that aggravates the vata, leading to vitiation of vata in that area, that is dosha prakopa, and which in turn leads to karmahani of the bahu. And it includes the various aharaja and viharaja factors. Aharaja factors like katutikta lakhu, sukshma shita guna aharas intake, which vitiates vata. And viharaja, it is like activities like excess plavana or swimming, bharahana, lifting heavy weights in excess, balavat vigraha, fighting with someone who is having more strength than you. Then dukkha shaya, that is the irregular body postures or lying down, irregular postures while lying down, or difficult or irregular bed. When we are lying down in irregular bed, etc. So such irregular postures can cause shoulder joint injuries. Now we will just go through the explanation given by various acharyas, and first we will be considering Madhukosha commentary from Matha Nidana. It says that Amsa desha sthido vayu shoshayitva amsa bandhanam sira kunchastasto janayat apabahukam. It is sira akunjana. So we can consider the sloka into two halves. So slokartha, first half, it is Amsa Shosha. So Madhukosha Tika, it has been mentioned that the first part of the line of sloka it indicates a condition called as Amsa-shosha, where due to the nidanas there is drying up of the shleshma in the Amsa-sandy, leads to atrophy or muscle wasting. So that is Amsa-shosha, and that condition is Kevala Vataja. And second stage, it is Sira Kunjas Tatrasto Janeti Apabahuka. So Akunjana of the Amsadesha Siras. It occurs and it causes Apabahuka. And this condition is considered by Madhukosha as Vata Kafaja. So Kapha is also involved in this Sira Kunjana or obstruction in the Siras. So Mata Vidana has mentioned two conditions, that is Amsa-shosha and Apabahuka. These are preliminary stages, Amsa-shosha, and the subsequent condition is Apabahuka, second stage. And next is the explanation given by Ashtangarde or Vagbada. There is Amsa Mula Sthido Vayu, Sira Sankoji Tatraka, Bahu Praspandida Haram, Janayati Abhavakam. So here, Amsa Mula Sthido Vayu. So vitiated Vata is present in the Amsa Mula. It vitiates the Amsa Mula or the shoulder region. Sira Sankoji Tatraka, and it dries up the, it does the Sankoja or construction of the Siras in that area, and produces Bahu Praspandida Hara. Praspandanam Sharirasya Chalanam Idam Vyanasya Karmam. So Praspandanam means movement. And it is the function of Vyanavayu. So here Vyanavayu is vitiated, and Praspandida Hara means there is a loss of movement or impaired movement of the upper limb. And also Shula is also a main symptom, even though it is not directly mentioned. Shula is present since the condition is Siras Gatavata or Snayu Gatavata. It comes under the Siras and Koja, etc. So there is a Siras Gata or Snayu Gatavata Lakshanas when we see it. Shula is a main symptom. So here Shula is also present along with Bahu Praspandita Hara. Also pain is a main characteristic of Vata Dushti. So when we see the Samprapti of Apabahuka, according to Matha, it is of two types, Vataja, and there is a Kafaja Nidana also, as this mentioned. So here we can see the Nidanas is Vatakara and Kafakara Nidanas are mentioned. So Vatakara Nidana, it produces Vada Prakopa of Yanavayu especially, and it gets the Sana Samshaya in Amsa, and it produces Shoshana of Sleshaka Kafa, Mamsa, Sira, Snayu and Kandara in that region, and it produces Sira Sankoja and Bahu Praspandita Hara, producing Apabahuka. Again, Kafakara Nidanas, it produces Kaf Prakopa and Azishtana in Amsa, and Lakshanas of Kafavrita Vyana in Sandhi is seen. There is Kafavrita Vyana Lakshanas in Sandhi. It is seen. Again, it indicates same, the pain and loss of movements are seen when Vyana is obstructed. So Sira Sankoja and Bahu Praspandita Hara, it produces symptoms and produces Apabahuka. And since Amsa Pradesha is a Marma Pradesha, Marma Bhigata Samprapti can also be considered. That is, the Abhidra and the Bahi Marma Bhigata causes will be there, and it produces injury to the Amsa Marma. Amsa Marma Abhigata occurs, and it produces affliction of Mamsa Siras Nayu Asti Kandara in that area, provocation of Vata and Bahu Cheshta Hara leading to Apabahuka is seen. And when on the context of Marma, it is explained that there are 4 types of siras that are present around the Marma Pradesha that nourishes this Nayu, Asti, Sandhi and Marma as a whole, as Sandhi as a whole. And any lack of nourishment of this siras or obstruction of this siras, it leads to Shosha of that area. So this can be considered as a Marmapikadaja Samprapti of Apabahuka. Now we will just see a few clinical conditions. These are common clinical conditions in modern science, which can be compared with the or the symptoms of which or features of which are similar to that of Apabahuka. There is no such single clinical condition which is correctly exactly correlated with Apabahuka, but many conditions or many diseases involving musculoskeletal and nervous conditions can be compared to the context of Apabahuka. And I have explained a few important ones, the symptoms of which are similar to that of Apabahuka, that is adhesive capsulitis or frozen shoulder. Frozen shoulder is the common term or the layman term. Adhesive capsulitis is the medical term. Then rotator cuff tendinitis, where the tendons of the rotator cuff muscles are, or impingement syndrome, are compressed. Impingement syndrome. Then cervical spondylosis of the cervical spine. Then bicipital tendinitis and tendon of the biceps. And then osteoarthritis of shoulder joint, etc. So these conditions are important conditions which can be correlated with features of Apabahuka. So first one is adhesive capsulitis, and common name of the English or layman call it as frozen shoulder. It's usually the pain and restricted movement of the shoulder, usually in the absence of an intrinsic shoulder disease. So there is no specific intrinsic shoulder disease, but there is pain and restricted movement of the shoulder. It's usually seen in the middle age and especially more seen in women. Then it can be associated with systemic disorders such as MI or heart problems or diabetes, metabolic diseases like diabetes mellitus, then thyroid disorders, etc. In such persons, these are usually this symptom is usually seen. This frozen shoulder condition is usually seen, or these people are said to be in the risk group of frozen shoulder. Occurs due to prolonged immobility of the arm. When you keep your shoulder joint immobile for a long period following in surgery, or bedridden if you are bedridden, or wearing a shoulder sling for a long time, such cases it causes inflammation in the capsule, that is adhesive capsulitis. Patient often complains of night pain which disturbs their sleep. So when we palpate the shoulder, it is tender and both active and passive movements are restricted. Even if you try to lift the hand, elevate the hand or abduct the hand, it is also restricted. Then main pathology is that the capsule of shoulder is thickened and a mild chronic inflammatory infiltrate and also fibrosis. So both will be present. Fibrosis or scar tissue will be present along with inflammatory infiltrate. And the diagnosis is made by physical examination, and it can be confirmed by arthrography. Arthrography is nothing but injecting a dye into the short joint, and X-ray or CT, etc. are taken to visualize the pathological area completely. We'll just see a special test for clinical examining the frozen shoulder condition. There is some movement exercise, movement test, range of movement is being examined here. The patient is asked to raise his hand towards his neck and perform an action such as combing hair. It's similar to actions such as combing hair or putting on a necklace, because these are daily activities which is usually hampered during manifestation of a frozen shoulder condition. So the patient is asked to elevate his hand to his neck and mimics the actions such as combing hair or putting a necklace, etc. That is their shoulder flexion plus abduction or external rotation. These are the movements that occurs. Also then he is asked to raise his hand to the scapula of the opposite side. That is shoulder extension takes place, adduction takes place, and internal rotation of the arm takes place. It is similar to fitting a hook behind of your dress or putting on a jacket or getting into the back pocket. So these actions means movement of hand to the opposite scapula behind. Then also hand to the opposite scapula the anteriorly. That is shoulder flexion plus horizontal adduction. It's the scarf test, or like just like you are removing or taking a scarf from the opposite shoulder. It's also a cross body adduction. Then Apley's scratch test. again, these are similar. As what a different name is being given. That is, you have to touch the opposite shoulder in the front, and the range of movements in the shoulder joint is adduction, horizontal adduction, internal rotation, and scapular protraction. The scapular raises. Touch the opposite shoulder in the back. Again, abduction, external rotation, scapular protraction, elevation, and upward rotation. So last one is touch the opposite scapula from behind. Here adduction, internal rotation, and scapular retraction and downward rotation. Okay, so these are some basic clinical examinations by which we can diagnose or assess the extent of pain and loss of range of movements in frozen shoulder. So rotator cuff tendinitis and impingement syndrome. So rotator cuff tendinitis means the tendon of there's a common tendon of the rotator cuff muscles. So rotator cuff muscles are those muscles which I have mentioned as SITS as a mnemonic due to inflammation of the rotator cuff muscles tendon. SITS, SITS. That is, you have to just remember supraspinatus, infraspinatus, teres minor, and subscapularis. So these four muscles, common tendon unites in the shoulder joint, and impingement of this tendon between the bones, that is impingement syndrome or the rotator cuff tendinitis. So most commonly affected muscle among this is supraspinatus tendon, and this is because of the repeated impingement between the humeral head and the undersurface of the anterior third of acromion process and coracoacromial ligament. So not going much in anatomical details. So the tendon is getting impinged in that area. Also, there is a reduction in the blood supply on abduction of the arm. On abduction, the blood vessel supplying that area is also compressed, and there is a reduction in the blood supply. So all this causes pain and loss of lack of range of motion. Then pathology, it begins with edema in the area and the hemorrhage of rotator cuff tendon. So it starts breaking, tearing, which evolves to fibrotic thickening and eventually to rotator cuff degeneration, and eventually degeneration of it occurs with tendon tears and bony spurs. The clinical features, it include pain in shoulder with loss of range of movements, especially abduction and external rotation. Night pain is present, sleep is disturbed, there is local tenderness and muscle weakness, there is functional impairments, there is difficulty in lifting, pushing, or overhead movements like cricket bowling action. You might have heard of bowlers, fast bowlers of Indian team who had rotator cuff syndromes and and had to take a break from sports for a while. I think Srishant had it. And movements with hand behind the back. MRI and ultrasound are employed for diagnostic imaging. And the next condition is biceps tendinitis or bicipital tendinitis. The tendons of the biceps muscle, it is inflamed. Biceps have already a short head and a long head. And the long head of biceps is involved here more. The overuse of it, it can cause micro tears in the fibers, and it leads to inflammation in the tendon. Or if any bony spurs are present due to arthritis in that area, it can rub against the tendon and it can cause micro tears. Symptoms include pain and tenderness in the anterior aspect of the shoulder, and pain on flexing the shoulder and external rotation. Then stiffness, weakness in overhead lift. So if you are trying to raise your arm overhead, there will be weakness. And the clinical test to examine this is the Yergason's test. And you have to make the patient sit or stand in this test for performing this test. Either can be seated or in a standing position. The humerus is to be, or the shoulder is to be held in the neutral position, and elbow should be 90 degrees flexed and pronated. The arm is pronated. Then the doctor will be wrapping his hand at the wrist of the patient, and the patient is asked to rotate and supinate the arm against the manual resistance applied by the doctor in the wrist. And if pain is reproduced in bicipital groove, the condition is said to be positive of tendinitis. Now we will just see certain clinical examination procedures or special tests that can be conducted to diagnose the various shoulder joint pathologies, including rotator cuff tendinitis or subacromial impingement, etc., or frozen shoulder. I have already mentioned. Some special tests have been mentioned here, like clinically, if you examine the range of movements, there will be pain or weakness with external rotation if shoulder joint is involved. Then special tests include Hawkins-Kennedy test, Neer's test, painful arc sign, and empty can test. So painful arc sign is a bit important because it can be asked for your examinations commonly. So Hawkins-Kennedy test, I'll just explain all the tests. Hawkins-Kennedy test, that's the examiner places the patient's shoulder in 90 degrees of the shoulder flexion, as seen in the picture, with the elbow flexed to 90 degrees again, and the patient then, the doctor then internally rotates the arm. When the arm is internally rotated in this position, the pain is felt by the patient. That suggests the subacromial impingement and rotator cuff tendinitis. The next one is Neer's test. It's a simple test. It's used to identify possible subacromial impingement syndrome. The technique is that the examiner should stabilize the patient's scapula with one hand. So in the picture you can see he's stabilizing the scapula by holding it. And while passively flexing the arm is flexed, the shoulder is flexed, that means it is raised, and it is internally rotated. And if the patient reports pain on this position, then the result of the test is considered as positive that there is subacromial impingement syndrome. Then another one is the empty can test. Empty can. You are emptying a can. The action is similar to emptying a can. So it's used to assess the supraspinatus muscle and the supraspinatus tendon. The patient's arm should be elevated to 90 degrees in the scapular plane with the elbow extended and in full internal rotation and pronation of the forearm. So it can exactly as shown in the picture. This results in a thumbs down position. You can see the thumbs down position in the picture, as if the patient were pouring liquid out of a can. He is emptying, as if he is emptying something from a can. Stabilize the shoulder while applying a downward directed force to the arm. That you can see the doctor is holding his arm, and by that he is giving a directed downward force to the arm, and patient is trying to resist that action. And the test is considered positive if the patient experiences pain or weakness with resistance. So in that condition, if patient feels pain or weakness with resistance, you can see there is an involvement of a superior supraspinatus muscle or supraspinatus tendon. The painful arc sign, it is one of the most important clinical examinations being used to identify the impingement, subacromial impingement syndrome. So here the patient either should be sitting or standing position, and he can be instructed to abduct the arm in scapular plane. So here he is seen abducting the arm. This test is considered positive if the patient experiences pain between 60 and 120 degrees of abduction. So here in that picture you can see the angles being marked in pink, that is between 60 to 120 degrees while raising. Initially the patient is having no pain, and when it reaches around 60 degrees the pain starts, and he still continues to raise if he is able to. If he is not able to, you have to stop it, but if he is able to lift, still he can lift up, and you can see that when it reaches 120 degrees of abduction the pain reduces again. So that area 60 to 120 degree, that is the glenohumeral painful arc. That is where the impingement of the tendon is occurring, the glenoid cavity and the humerus, the joint is placed. So which reduces, the pain reduces once past 120 degrees of abduction. And if we continue, if the pain is occurring at above 170 degrees, it indicates acromioclavicular issues. That is something different. Acromioclavicular issues, its pain occurs after 170 degrees, because at that angle only the area is activated. If there is any osteoarthritis in the acromioclavicular joint, you can feel pain at about 170 to 180 degrees. And if there is pain throughout, it indicates osteoarthritis of the glenohumeral area too, or the area mentioned earlier. All this, the whole joint is having osteoarthritis. Then he can get the pain throughout the painful arc. So that remember this, the area between 60 to 120 degrees of abduction. If the pain, if the person is getting pain while elevating his hand, elevating his shoulder or his arm, and getting pain in 60 to 120 degrees, then it is a subacromial impingement syndrome. And a similar condition called as Vishwachi is also explained by Acharyas. And the word Vishwachi is derived from two words, that is Vishwat plus Anch. So Vishwa means entire, the whole, all pervading. So entire is mentioned as Vishwa, and Anch means turned to or directed towards or to move or to wander about. So thus Vishwachi literally means spreading throughout an area. That here it is the arm. Here what happens is that Vata affects the Khandaras. Khandaras includes here muscles, tendons and ligaments all can be considered, that run to the tip of the fingers from behind the root of upper arm, causing restriction of movements and pain. And pain often has a neuritic quality here. It is described as throbbing pain or burning pain or stabbing or electric shock like hand aching type of pain. So all such kinds of pain can be seen in this condition. And Dalhana has considered this disease resembles Gridrasi of one arm, resembles Gridrasi as it affects in one arm. In Gridrasi it is one leg, and here it is one arm. So Gayadasa, Vijayarakshita and Aranatha in all their commentaries have stressed the point of occurrence of pain as the cardinal feature in the disease. So all these commentators have mentioned like that, but Acharyas have mentioned only Bahu Karmakshayakara, or loss of movement or loss of function of the arm. And when you consider the symptoms or the explanation given by Madhavadana and Ashtangradaya, you can see in Madhavadana it is mentioned Talam Pratyangulinam Ya Kandara Bahu Prishtada Bahu Karmakshayakari Vishwaji iti Hisva Smrita. So Talam Pratyangulinam. Talam is Hastasya Upari Bhaga, or the posterior aspect of the arm. Bahu Prishtam Bahu Prishtam. Tataha Arapya, and it starts from the arm, root of the arm. Tataha Arapya Hastatalam Lakshikritya Angulinam, and it travels towards Lakshikritya, towards the Anguli. So Talam Pratyangulinam, so that is the direction of pain or the radiation of pain. Talam Pratyangulinam Ya Kandara Bahu Prasthita. All the Kandaras present in these areas are affected, and it produces Karmakshaya of Bahu. Kandarastha Samdushya Bahu Karmakshayakari. It produces Grahana and Akunjana of the Kandaras. Talam Pratyangulinam, according to Ashtanga Hridaya, Talam Pratyangulinam Ya Kandara Bahu Prishta. That is similar to the first line of Madhavadana. And second line it is told Bahu Cheshta Abaharini Vishwaji Nama Sasmrita. So he has mentioned Cheshta Abahara or impaired and loss of movement instead of Karmakshayakari. That is the only difference. And so the Lakshanas in total, it is both Acharyas have mentioned Karmakshaya, But we have to consider pain also as a symptom, because it is radiating from Bahu Prashta to the Hastatala towards Anguli, since it is caused by Vata, and also it is a Sirasana Ayurveda Vata, and also all the commentators have mentioned pain also as a symptom of Vishwachi. Khali is another condition that is mentioned by Charaka. It is Vishwaji, Grudrasi, Chaokta, Khali, Tivra, Ruja, and Vida. The condition when Vishwaji and Grudrasi occurs together, it is associated with Tivra Ruja, severe pain. This condition is called as Khali, and also Khali to Pada, Jangha, Uru, Kara, Mula, Avamotini. Avamotini means there is a twisting action or twisting kind of pain in Pada, Jangha, Uru, and the shoulders, that is Karamula. So in all these positions there is a twisting kind of pain seen. So this condition where Gradrasi and Vishwaji, it occurs together in a person, it is called as Khali. So there are many conditions which looks like similar, which are similar to this Apabahuka and Vishwaji. And when we consider Sapaksha Nidana or differential diagnosis of these conditions, those conditions which can be taken in case of Vishwaji, it is Manyastambam, Apabahuka, Amsa-shosha, and Ekangavada. So in Manyastamba, what happens is that there is Diva Swapnam, Asamasthana, Vibradotva, Nirikshana, Manyastambam, Prakrutesa, Eva, Sleshma, Avrta. So there is a particular correct etiology is explained in case of Manyastamba, that is Diva Swapna is the reason. Vivritha Urdhva Nirikshana is the reason. That is a particular etiology that is mentioned. And also it has a Kapha predominance or association with Kapha dosha, and pain will be here locally, mainly on the Manya Pradesha or the neck. Whereas in Apabahuka it is on the shoulder, and Vishwachi it is throughout the arm, so radiating pain throughout the arm. And Apabahuka, it is Amsa Mulasthita that is mentioned. Amsa Pradesha is mentioned. And Amsa Shosha again, Amsa Shosha it is there is wasting is seen more in that condition. And in Ekangavada, there is Padam Sankoche, Ekam, Hastam Va, Toda Shulakru. So there is the complete paralysis of a Pada or Hasta, that is in Ekangavada. Eka, one Anga is related. So it can occur in either in leg or the arm, but there is a complete paralysis along with Toda and Shula. So when we rule out all these conditions, it can be, Vishwaji can be confirmed. So these can be written in case of Apabahuka also. In Apabahuka, Vishwachi can be mentioned. Here, Apabahuka is mentioned. So when we are considering the Sapaksha Nidana of Apabahuka, Vishwaji can be included here. Now I'll just mention few conditions that has similar features like that of Vishwachi. It's the conditions like brachial neuralgia or irritation of brachial plexus or cervical spondylosis, etc. These can be compared with Vishwachi. Cervical spondylosis, it can also mimic Apabahuka. So I explained it here. Brachial neuritis is also known as neuralgic amyotrophy. It's a rare syndrome of unknown etiology affecting the lower motor neurons of the brachial plexus, or it can affect individual nerves or nerve branches like a radial nerve, ulnar nerve, median nerve, etc. and the muscles it supplies. So it's usually characterized by acute onset of excruciating unilateral shoulder pain followed by flaccid paralysis. Here it is a lower motor neuron lesion, so there's a flaccid paralysis of the shoulder and parascapular muscles several days later. The syndrome can vary greatly in presentation and nerve involvement. So depending on the root of the nerve and the nerve involved, the syndromes can vary in presentation. The pain area of the pain can vary in presentation. And the symptoms, it has sudden onset on pain in neck, shoulder, arm weakness and difficulty in moving the arm and shoulder. And there is numbness in the shoulder, arm, hand, fatigue is present, then malaise is present, headache is present, muscle aches and pain is also present. So the pain here occurs throughout the pain and weakness occurs throughout the course of the nerves arising from the brachial plexus. Just see symptoms of irritation of the brachial plexus. There will be paresthesia or tingling sensation or abnormal sensation like pins and pricks or needle pricking throughout the area of the course of the nerve. Then the numbness is present, also tingling sensation along the distribution of the nerve root, along with neuralgic pain along the course of the nerve. I'll just say common causes of brachial neuralgia and irritation of brachial plexus. Such neuralgia and irritation of brachial plexus can be due to a prolapsed intravertebral disc in the cervical area or the osteoarthritis of the cervical spine, and where there is a compression due to osteophyte formations. When there is osteoarthritis, the osteophytes are formed in the joints, in the vertebrae spine, and these osteophytes can compress the nerve. Then cervical rib syndrome. Cervical rib is an extra rib that forms above the first rib, growing from the base of the neck or just above the collarbone. It is usually congenital, and it's an abnormality that's present from birth. Usually it may be asymptomatic, but if it starts pressing the nearby nerves and blood vessels, it can cause pain and numbness in the arm, usually called as thoracic outlet syndrome. Then sagging of the shoulder girdle, sagging or hanging down of the shoulder girdle following a trauma or a weakness of the muscles, etc. Then malignant infiltration of the base of the neck, any cancerous conditions or a spinal tumor can produce neuralgia. Any growth near the brachial root causing compression, or a traction injury in the road accident. So these are many causes. There are many causes, and these are the main causes which can cause brachial neuralgia or irritation of the brachial plexus. And the symptoms arising, it usually mimics the symptoms told in Vishwaji, that is pain and weakness of the arm. And the last point, in this condition, cervical spondylosis, it can be compared. It can occur. You can compare, the features can be included either in Apabahuka or Vishwaji. But mainly the radiating pain, it suggests it can be related to Vishwaji. Then spondylosis describes the degenerative changes within the vertebrae and the intervertebral disc. It occurs during aging. Secondarily, due to trauma or rheumatoid disease. So primarily it was due to aging. There is changes, degenerative changes in the vertebrae, and secondly it may be due to trauma or a rheumatoid disease. And symptoms include osteophytes is present as local bony growth, which can be found in radiography. Then congenital narrowing of the spinal canal is seen. Then intervertebral disc degeneration with posterior or lateral disc protrusion. So disc protrusion is seen. So here the posterior or lateral disc part of the disc is protruded. Then ischemic changes in the cord and the nerve roots are also changed, loss of blood supply in that area. And the pain depends upon the area of disc protrusion. So usually a patient complains of pain in the arm. And if the protrusion, the most common protrusion is in the cervical 5 and cervical 6 area. It's root pain. The root pain arising from this area, it can radiate into the C7 myotome, or the nerve supplies the muscles, triceps, or deep to the scapular and extensor aspects of the forearm. So all this area there will be radiating pain if C5 C6 protrusion is present. In C7 root lesion, in the C7 area of the protrusion and root lesion, there is weakness and wasting of the triceps muscle, the wrist, and the extensor muscles of the fingers. And there is loss of triceps jerk in advanced conditions. And there is sensory loss in the C7 dermatome area, the skin which is supplied by the C7 area. There will be sensory loss also in later stages.